Neurological examination of the upper limbs. Begin this examination by asking the patient to remove his or her shirt and to sit over the edge of the bed.
Hello Richard, nice to see you. I'd like to examine your arms. If you wouldn't mind taking your shirt off and sitting on the edge of the bed, and I can do that.
Examine the motor system systematically every time. Inspect for wasting, both proximally and distally, and for fasciculations. Don't forget to include the shoulder girdle in your inspection.
Okay. I'd like you to put your arms straight out in front of you like this with your palms up, and then close your eyes and just hold them there.
Ask the patient to hold both hands out, palms up, with the arms extended, and to close the eyes. Look for drifting of one or both arms, which can be due to upper motor neuron weakness, a cerebellar lesion, or posterior column loss. Also note any tremor or pseudoathetosis due to proprioceptive loss. Feel the muscle bulk next, both proximally and distally, and note any muscle tenderness.
Do you have any pain?
Test tone at the wrists and elbows by passively moving the joints at varying velocities. Assess power at the shoulders, elbows, wrists and fingers.
Okay, just shrug your shoulders up for me please. Push up hard. Okay, that's good.
Shoulder abduction. Ask the
Next,
patient to abduct the arms with the elbows flexed and resist your attempt to push them down. Adduction. Ask the patient to adduct the arms with the elbows flexed and not to allow you to separate them.
Towards your sides. Hard. That's good. Thanks.
Elbow flexion. The patient should bend the elbow and pull so as not to let you straighten it.
Pull hard. Yep, harder. Okay, it's good. And now, I'd like you to put your thumb towards your face and pull up again. Pull up hard. Okay, relax. And try this side. Pull towards you. Okay, relax, change the angle. Thumb up towards your nose and pull towards you. That's it, good.
Extension.
All right.
The patient should bend the elbow and push so as not to let you bend it.
Now, just straighten your arm down towards your knee. Hard. Okay, that's good. And this side, down towards your knee.
Wrist flexion. The patient should bend the wrist and not allow you to straighten it.
Don't let me straighten it up. Okay, and this side. Keep it flexed. Good. I'd like you to put your wrists, cock them up straight.
The patient should extend the wrist and not allow you to bend it.
Straighten them. That's good.
Finger extension. The patient should straighten the fingers and not allow the examiner to push them down.
Now you put your fingers straight out and hold them there. Good.
Finger flexion. Ask the patient to squeeze 2 of your fingers.
I'd like you to just
never
squeeze
offer
hard
3.
on my fingers. Now again, squeeze these hard, don't let me take them out. That's good. Okay. On your
Finger
knee,
abduction.
just spread your fingers
The
apart
patient
like
should
that.
spread out the fingers and not allow you to push them
So
together.
don't let me push these fingers together. That's good. And spread these fingers apart. Just rest them there. Again.
Finger adduction.
There, resist
Ask
me
the
pulling
patient to
them
keep the fingers together against your attempts
Now
to
we're gonna do the
separate them.
outside. And resist me pulling your fingers apart. Resist.
Now test for an ulnar nerve lesion.
That's good.
Frohman's
I'd
sign.
like you to hold this card
Ask the
as I'm
patient to
doing it,
grasp a piece of
and
paper
keep
between
a
the
good
thumb
grip on
and
this
lateral
card and
aspect
don't
of the
allow me to
forefinger
move it.
on each hand. If the sign is positive, the affected thumb will flex because of loss of its
This side.
adductor muscle.
Again, grip it tightly. Hold it there. Good, thank you.
And now test for a median nerve lesion, pen touching test. Ask the patient to lay the hand flat, palm upward on the table, and attempt to abduct the thumb vertically to touch the examiner's pen held above it.
Now hold that thumb in
This
that
may be
position.
impossible
Don't
if
allow
there is
me
a
to
median
move
nerve
it.
palsy at the wrist
That's
or
good.
above.
And on this side, again, touch the tip of the pen Gets your thumb in the right position, and now hold that there and don't let me put it down. Yeah. Okay.
Now test the
I'd like you just
reflexes.
to fold your arms
Begin with the
loosely
biceps
back
jerk.
and just
Place one forefinger on the biceps tendon and tap this with the tendon hammer. The hammer should be held near its end and the head allowed to fall with gravity. Normally, if the reflex arc is intact, there is a brisk contraction of the biceps muscle with flexion of the forearm at the elbow. This is followed by prompt relaxation. If a reflex appears to be absent, always test following a reinforcement maneuver. For example, ask the patient to clench the teeth tightly just before you let the hammer fall.
Okay, I'd like you to clench your teeth very tightly, please. Go now. And relax. Do it again. And relax.
Now test the triceps jerk. Support the elbow with one hand and tap over the
hold your arm
triceps
like that.
tendon.
Stay loose.
Normally, triceps contraction results in forearm extension.
And again, just relax this arm right there.
The brachioradialis or supinator jerk is next. Strike the lower end of the radius just above the wrist. To avoid hurting the patient by striking the radial nerve directly, place two fingers over this spot and then strike the fingers. Normally, contraction of the brachioradialis causes flexion of the elbow. Now test the finger jerks. The patient rests the hand palm upward with the fingers slightly flexed. The hammer is struck over the examiner's fingers, which have been placed over the patient's. Normally, slight flexion of all the fingers occurs.
Just relax your fingers there.
Examination of coordination tests cerebellar function. Begin with the finger-nose test. Ask the patient to touch his or her nose and then your outstretched finger. Demonstrate the movements.
Touch your nose, and now reach out and touch my finger.
Look for
And go back
intention
and
tremor,
forth as
which
quickly
is
as you
tremor
can.
increasing as the target is approached, and for past pointing, where the patient's finger overshoots the target towards the side of the cerebellar abnormality.
Let's try the other side. Okay, that's good. What I'd like you to do is on the back of your hand, I'd like you to take your other hand and to alternate front and back like that, and then go as fast as you can.
Now test the patient's ability to perform rapidly alternating movements. Slow
other
and
hand now,
clumsy
I'd like you to do the
performance
same
of these
thing, but
movements
lift
is
it up,
called
before you go back down.
dysdiadochokinesis.
Okay, right, Rich, what I'd
Now
like you to
test
do this
rebound.
time.
Ask the
is
patient to
with
lift the arms
your
rapidly
are
from
by
the
your
sides and then stop.
And then you're going to lift them straight up with the palms up
Hypotonia
like that,
due to
and then
cerebellar
stop in that
disease
position.
causes
Continue
delay
to do
in
it
stopping
with
the
your eyes
arms.
shut, and then do it quickly. Okay.
Remember that muscle weakness may also cause clumsiness,
Okay, and
but
once
motor
more.
testing should have revealed any impairment of this
Thank
sort.
you. And can you put your arms straight out now? And now just close your eyes and hold, and keep your hands in that position, even though I'm going to try to move them. Okay, thank you.
It is usually best to examine the sensory system last. It can be a difficult examination because it is subjective. Look for scars that may have caused nerve damage. First, test the spinothalamic pathway, pain and temperature.
What I have here is a pin. It's been blunted, so it shouldn't hurt, but it should still feel sharp. And I'm just going to demonstrate it by touching your chest. Now, does that feel sharp?
Yep.
Okay, and does it feel sharp on this side? Right, I'm going to be touching you on your fingers and various parts of your hands, and you just tell me when you feel it is sharp, but your eyes need to be shut. Okay? All right.
Yep. Sharp.
Test each dermatome. Map the abnormal area and fit any sensory loss into a pattern. Test that the patient understands that the sensation should be sharp by turning the pin over and touching with the blunt side occasionally. Always use a disposable neurological pin. It is not usually necessary to test
thank you.
temperature. Next, test the posterior column pathway, vibration and proprioception. Use a 128 Hz tuning fork to assess vibration
So with
sense.
this, tell me what do you feel when I put it there?
It's vibrating.
Okay, and on this side?
It's vibrating.
All right. Now, I'd like you to close your eyes, and I'm going to actually touch your fingers, and you just tell me when you can feel it.
It's vibrating.
Now, what I need you to do is tell me when it stops.
It's stopped.
Okay.
If the vibration sense is absent distally, try again on the wrist, elbow, and if necessary, the shoulder. Now examine proprioception, starting with the distal interphalangeal joint of the little finger.
I'm going to push it down. All right, with your eyes closed.
Down. Down. Up.
Okay, I'm going to try this side. Keep your eyes shut.
Up. Down.
Movement of a few degrees is usually detected by the patient.
This is a cotton ball, and I'm going to do the similar...
Test light touch with cotton wool. Touch the skin lightly, but do not stroke in each dermatome.
Okay.
Yep. Yep. Yes. 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 Yep.
Did it feel the same on both sides?
Yes.
Okay.